Good morning, good afternoon, good evening, and welcome to today's webinar. My name is Laura. I am the Executive Manager of the World Stroke Academy. It is with great pleasure that we are hosting this webinar on key highlights from the World Stroke Congress 2024. We have exceptional speakers that will be sharing their expertise on the topic. And we organize this webinar jointly with the European Stroke Organization, which I very much like to thank for their support. Before we introduce today's chairs and speakers, we're going to have a very quick look at some of our housekeeping rules, just as usual. We welcome any questions that you have, but we kindly ask you to use the Q&A box for those so they can be addressed in the Q&A discussion at the end. You can, of course, use the chat box to say hi, tell us where you're joining us from, or leave any comments you wish. A reminder, of course, that the webinar is recorded and the recording link will be sent out to you via email shortly after the webinar, and it will also be uploaded on our site. And lastly, we kindly invite you to fill in the evaluation survey at the end to share your feedback with us, but also to claim your certificate of attendance. Now, without further ado, let me introduce today's chairs. We are very lucky to have Professor Jairam Pandyan, WSO President, and Professor Simona Sacco, ESO President, joining us today. Thank you, and the floor is all yours.
Yeah, thank you, Laura, and I thank all the participants who have joined for this webinar. And this is an initiative of looking at the World Stroke Congress that was held in Abu Dhabi last month, and reviewing all the scientific papers, award sessions, and also groundbreaking trial results. So in this webinar, we are going to cover some of the important findings that were presented at the World Stroke Congress in Abu Dhabi. And so the first speaker would be Dr. Luciano Supasto, and he's going to talk to us about an innovative and screening of cardio-aortic thrombus in acute ischemic stroke using an extended CT angiogram. Over to Professor Supasto.
Thank you very much, Jairam. Let's see. Can you see my slides there?
Yes. Yes.
Okay, excellent. Thank you. So thanks so much for the invitation. As you just heard, we're going to try to summarize the results of the DAYLIGHT trial, in which we conducted a randomized controlled trial comparing an extended CTA versus standard CTA in the hyperacute stroke setting. So these are my disclosures. And in terms of the background, we know very well that about 25% of cryptogenic strokes remain with 25% of all strokes are cryptogenic. So we don't have a clear explanation for a large proportion of ischemic strokes and TIAs. And one of the main reasons is that we only use, in the majority of the cases, we only use a TTE, which only has a 1% diagnostic yield for cardioembolic sources. And there's a very low availability of TEEs around the world. We know this based on several surveys that have not changed through several years. And I'm sorry, here is TTE, not TE. So the problem with TTEs mostly is that that left atrial appendage thrombi are missed because we cannot image it with a transthoracic echocardiogram. So since things have not changed in about 10 years in terms of how we look for cardioembolic sources, we thought that we should try to leverage the tools that we use for hyperacute stroke treatment, such as computed tomography and angiography, and see if by using that we can detect more thrombi. So the objective of the DAYLIGHT trial was to assess the efficacy and safety of performing a non-gated single phase head and neck CT angiography extended 6 centimeters below the carina as part of the hyperacute stroke protocol, compared to standard of care CTA for detecting cardio-aortic thrombi. We conducted the trial in London Health Sciences Centre in London, Ontario, Canada. It was a prospective single-center randomized open-blinded endpoint trial. And although it's a single center study, we serve 13 sites in southwestern Ontario, as you can see here, with a catchment area of 2 million people. And all these centers that you see in red send their patients for a thrombectomy, and the ones that you see in white send their patients to us for thrombectomy and TPA or TNK. So between July 17, 2023 and May 6, 2024, we randomized one-on-one all patients coming to the emergency department under a code stroke, or patients for whom a code stroke was activated on the floor. And all patients received at least a TTE and a 14-day Holter plus advanced cardiac imaging when needed. Half of the patients were randomized to standard of care CTA, and the other half was randomized to an extended CTA. Just for you to understand what we did during the first phase of the CTA, this is what the amount of thorax that can be imaged with a standard of care CTA. And this is what we added by using an extended CTA. And you can see very clearly here that we can image the left atrial appendage. So within the first phase, we did this, and then we continued with the second and third phases of the CTA and perfusion imaging when needed. The first or the primary efficacy endpoint was the presence of the cardio-aortic thrombus, defined as a left atrial appendage, left atrium, left ventricle, any thrombus within the aortic arch, or any ascending or descending aorta segments, valves, or any cardiac thrombi detected within 3 months post-randomization. The primary safety endpoint was the door to CTA completion, because we wanted to measure whether extending the CTA caused any delays in acquiring imaging. But there were other secondary safety endpoints in which we measured door to needle and door time to growing puncture time. So during the study period, we assessed 830 patients who were randomized to either standard CTA or extended CTA. 365 ended up not receiving a diagnosis of ischemic stroke or TIA, and the other 465 patients were the ones that were part of the final analysis. So in terms of baseline differences in terms of CTA, standard CTA or eCTA, we can see here that there were no substantial differences between groups in terms of demographics or qualifying events. Most of the patients had an ischemic stroke. The NIHSS was slightly different or slightly more severe in patients with eCTA, and the amount of patients receiving antithrombotic therapy before the stroke was similar as well. There were no significant risk factors differences, as you can see here in the table, and in terms of cardiovascular comorbidities, they were pretty well balanced. So in terms of the primary endpoint, which was a cardio-aortic thrombus, we found 1.7% in the standard of care CTA group, which means 4 out of 239 patients. And then we found 8.8% in patients undergoing an eCTA, as you can see here, with a significant increase in the number of cardio-aortic thrombi detected, almost a 6-fold higher chance of detecting a cardio-aortic thrombus. We performed sensitivity analysis adjusted for the presence of known AF or known AF plus baseline variables, or the on-treatment analysis, and the results were unchanged after performing this analysis. In terms of the secondary efficacy endpoints, we also found significant differences in the presence of thrombus, tumor, or vegetation in the eCTA group compared to the standard of care CTA. As you can see here, 9.7% versus 3.3%, with a 3-fold higher chance of detecting thrombus. When we used a wider definition of cardioembolic sources, such as treatable PFO or other cardioembolic sources that can be detected with an echocardiogram, we found no differences. And then among patients who had a thrombus, tumor, or vegetation, The ones that received a new treatment were 5.8% versus 3.3% in both groups without significant differences. But of course, the study was not designed to find differences in the third secondary efficacy endpoint because it was very clearly unpowered for this. In terms of a primary safety endpoint, which was a time to completion of the CTA since cold stroke activation, we found a 1.2 minute difference between, a 1 minute difference between both groups in both the intention to treat analysis and the as treated analysis without significant differences. So there was not a significant delay in acquiring the complete CTA. In terms of secondary safety endpoints, such as door to needle time or door to groin puncture time, we did not find any significant differences in the intention to treat analysis, but most importantly, we did not find differences in the as treated analysis with a tends toward a lower time for the ECTA compared to the SCTA. And I think this is just because of chance, but the most important message is that there were no differences in time to treatment, either with intravenous thrombolysis or mechanical thrombectomy. And then, of course, as expected, this was the fourth secondary safety endpoint, which was radiation exposure. As you can see here, measured in millisieverts. And there was a significant 1.2 millisievert increase in radiation exposure in the group receiving an ECTA compared to the standard CTA. And this is, of course, expected because the thoracic area receiving a CT was larger. But just for you to have an idea of what 1.2 millisievert means, it's about 2.5 mammograms or 10 chest X-rays. So that's the excess in amount radiation that patients got. So in terms of conclusions, adding a non-gated single-phase extended CTA to a standard of care diagnostic stroke workup increased the detection of a cardio-aortic thrombus by nearly 6-fold compared to the standard of care stroke workup. A non-gated single-phase extended CTA can be safely performed as part of the routine hyperacute cold stroke without causing any delays at the expense of a minimally increased exposure to radiation. And with this, I would like to thank Diana Ayan and Rodrigo Bagur, who Rodrigo is the co-PI and Diana is the director of the Brain and Heart Lab at Western University. And thanks to them, the study was possible. And of course, all the patients and co-investigators. Thank you very much.
Thank you, Luciano. Thanks for this excellent presentation and congratulations for this very important study that have results that can impact our clinical activity. And we will have time to discuss this study at the end of this session. And now it's my pleasure to introduce the next speaker, Signild Asberg from Sweden. The topic of her talk is optimal timing of anticoagulation after ischemic stroke and atrial fibrillation. Please, Signild.
Thank you so much, and thank you for inviting me to once again present the results from the Catalyst trial. See if it works for me to change the slides. So on behalf of not only me, but the Catalyst Executive Committee,
we cannot see your slides.
Oh, I'm so sorry. Thank you for letting me know, and let's see how we can. It did work so well, good when we tried. So I will try again. And now if...
Okay, here they are. You can go in presentation mode.
And how is that for you now? It's still presenter mode for you, yes?
The notes, it's not to the right.
Yeah.
Yeah.
And how about now?
Yeah.
It's good.
Wow. Wow.
Let's go.
And see if I can change the slides as well. So did I do that? Can you see the second slide with Catalyst on top of it? Good, great. So this is a collaboration on the optimal timing of anticoagulation after ischemic stroke and atrial fibrillation. And just short on background and aim. Recently, there have been several RCTs reporting data concerning safety and efficacy of early versus later start of DOAC after an acute ischemic stroke in patients with atrial fibrillation. But despite these trials, uncertainty remains. And therefore, the collaboration was started, and the aim of Catalyst was to assess whether early start was superior to later start of DOAC and explore effects in pre-specified subgroups, as well as confirming safety in terms of hemorrhage. Also, in our path towards this meta-analysis, we searched PubMed and Cochrane and Embase for trials that were pre-registered RCTs investigating clinical outcomes in patients with acute ischemic stroke and atrial fibrillation who were randomized to either early or later start of DOAC in appropriate dosage. We found 4 trials which had or almost had finished inclusion, Timing and Eland, who were already published at the time, and Optimus, which is published now, and also START, which is presented earlier this year and is submitted for publication. And even though that we investigated the same research questions, when to start DOAC after ischemic stroke and AF, there were differences between the trials. Randomization in some trials depended on stroke severity, and some trials it did not. One trial used adaptive design, and the others did not. The inclusion of spontaneous intracerebral or intracranial hemorrhage is in outcome, or if the outcome were measured at 30 days or at 90 days. If the trials were committed in just one city or in one country or one continent. So they were a bit kind of comparing apples and pears. So to overcome these differences, we performed an individual participant data meta-analysis in which we defined early as within 4 days and late as on day 5 or later. We also defined our primary outcome as a composite of recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke. So now we were comparing apples to apples. We also registered the trial on Prospero. And all patients had already given consent to share data in the original trials, and ethical approval was contained for sharing of data. And we used a simple template to extract only the information necessary for this edema. And further on in methods, as we expected, a low event rate of the primary outcome. We chose a one-stage edema. For all the outcomes, generalized linear mixed effect models was used, accounting for between trial differences. As in the original trials, we used the intention to treat principle. As already mentioned, the primary outcome was recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke at 30 days. The pre-specified subgroup analyses were on stroke severity measured by NHSS, reperfusion therapy, anticoagulation already on admission, and sex and age. So to close up this method section, we performed this meta-analysis with individual participant data from 4 randomized trials. We included more than 5,000 patients. 16% of these came from the study Timing, 14% from Eland, 67% from Optimus, and 3% from Start. So here are the baseline data, which were well balanced between the early group of 2,691 patients compared to the slightly larger group of 2,050 patients in the later arm. Mean age was around 78 years, and almost half of the patients were women. For stroke severity, the median NRS score was 6 or 5, which was meaning that almost half of the patients had a higher stroke severity score than that, which could explain also a bit higher proportion, which is normally seen outside of trials of reperfusion therapy, around 1/3. And here are the results for the primary outcome. The red line depicts the early arm, and the dotted black line the later arm. And as you can see, there were fewer events in the early arm compared to the later arm, 57 versus 83, giving an odds ratio of 0.7, which was a significant p-value of 0.04. Moving on to the subgroup analysis at 30 days, there were no interactions between the subgroups, meaning that the effect of early starting did not differ due to the stroke severity, reperfusion, anticoagulation, sex, or age. And when analyzing ischemic stroke separately from symptomatic ICH at 30 days, there were still fewer ischemic events, still significant results, 45 events versus 70 events in the ischemic stroke. And you can also note that the events occurred early on, just in a couple of days from randomization. And we did not find a difference between early or later arm in regards to intracerebral hemorrhages, which was actually one of the first initiative to do the trial. Did we do harm when we started early? And we can here see that we do not. So these are the primary outcomes at 30 days. And now we're moving on to secondary outcomes at 90 days. The pattern is about the same, numerically lower event rates of ischemic stroke in the early group, but now not statistically significant. Still no difference in ICH, and no difference in considering extracranial hemorrhages. And also looking, adding mortality, there were still lower event rates in the early arm compared to the later, but not statistically significant. See, and I think that's the same picture. Moving on to just a short roundup in conclusions. That Catalyst is the first individual participant data meta-analysis of randomized trials on the optimal timing of DOAC after acute ischemic stroke in patients with atrial fibrillation. And we can see and show that early start was superior to later start of DOAC regarding the primary composite outcome of new ischemic stroke, symptomatic intracerebral hemorrhages, and unclassified stroke at 30 days. And we can also see that this was consistent in the pre-specified subgroups, and we did not find a difference in major bleeding, including symptomatic intracerebral hemorrhages. So our findings do support early DOAC initiation in clinical practice. Just want to acknowledge that this trial could not have been done without any of these persons. We have the executive committee, the statistical committee, the British Heart Foundation also gave a research grant for Catalyst. We have all the trial principal investigators and all trial co-workers and finally all patients to give thanks for making this study possible. And also want to add one more slide. When I got the template from the Stroke Academy, they had this already given takeaway messages. So I used that slide too, just to give you something more to bring home. So when in doubt, do randomize. And collaboration do make us stronger. And when you do a meta-analysis, be aware not to compare apples to pears. And as already said, in patients with atrial fibrillation, DOAC initiation within 4 days after acute ischemic stroke reduced the risk of new stroke at 30 days. So a short glimpse from the presentation in Abu Dhabi. Thanks again to the Stroke Academy for inviting me here. So thank you all for listening.
Yeah, thank you, Dr. Asbak, and for the interesting results, the individual patient meta-analysis. And we will take up the questions later. So we'll move on to the next speaker, Dr. Fisher, and he's going to talk to us about the minimally invasive surgical treatment for spontaneous ICH. And over to Dr. Fisher.
Yeah, thank you very much. I hope you can see my slides. Can you see my slides? Okay, fantastic.
Yeah.
So the title of my talk is Minimally Invasive Surgical Treatment of Spontaneous Hypertensive Intracerebral Hemorrhage Trials. So these are my disclosures, but probably the most important disclosure is that I'm a curious person, and there are so many unanswered questions in clinical practice that we try to answer these questions by randomized controlled trials. And here you see an overview on the trials which I'm currently involved in. So ICH is a massive disease having a huge impact on the lives of many people. Overall, 15 to 20% of all strokes are related to ICH, and 2 million people in the world each year are suffering in ICH. Even in high-income countries, case fatality is 30 to 40% at 1 month, and only 20% of these people regain independence. So ICH accounts for 1 in 3 incident strokes according to the Global Burden of Disease report from 2013, 49% of 6.5 million stroke deaths, and 58% of disability-adjusted life years lost. So blood does not belong into the brain because it produces a further damage there, and eventually our patient can even die. So we do have to remove these clots, but the main question is, how can we effectively remove the blood from the brain without producing any harm to our patients? So let me start with the traditional trials comparing conventional craniotomy versus best medical treatment. And these trials are quite historic already. They have been done more than 20 years ago. The first trial, the best trial, is the so-called Stitch trial, which was a British trial, very well performed, where people with an intracerebral hemorrhage were randomized into either conventional craniotomy versus best medical treatment. And here you see the Kaplan-Meier curve of the Stitch 1 trial, which has been published in The Lancet in 2005. And if these lines would not be in color, you would not be able to make any difference out of these two lines. However, a subgroup of the analysis of the Switch trial suggested that people with lower ICH might have a benefit of conventional surgical approaches. And that was the main reason why the Stitch 2 trial has been performed. And this trial was published in The Lancet in 2013. And here you see the Kaplan-Meier curve. So early surgery compared to initial conservative treatment was showing a tendency of a better outcome and lower mortality in the early versus the early surgery versus the initial conservative treatment. However, there was no statistical significant difference in outcome. So what about minimal invasive surgery? The colleagues from UK, from Professor Mendeloff, they did a meta-analysis of all existing trials at that time point. And if you see overall, it looks that surgery favors, is linked to a favorable outcome compared to control treatment, especially if you perform minimal invasive surgical approaches. And there was another meta-analysis which was published 5 years later, and they were comparing minimal invasive surgery versus any other treatment. So that means medical or conventional craniotomy. And as you can see here, it looks like that people treated with minimal invasive surgery are having a better outcome. Furthermore, they also compared minimal invasive surgery versus conventional craniotomy on the modified ranking scale. And also here you see that there's a tendency that these people have a better outcome. So are there any trials on minimal invasive surgery versus conventional craniotomy? And yes, there was a very nice trial which has been presented at the World Stroke Congress in Abu Dhabi. This was a Chinese trial, and what they did, they randomized 733 people in 3 groups. So they had one group with endoscopic surgery, one group with aspiration, and one group with craniotomy. And here you now see the modified ranking scale at 6 months. So here you see the endoscopic group and the aspiration group, and here you see the craniotomy group. And overall, if you look at modified ranking scale of 0 to 2, it tended to be lower in the people with the conventional craniotomy compared to people having either endoscopic or aspiration surgery. So overall, they concluded that compared with small bone flap craniotomy, endoscopic surgery and stereotactic aspiration improved the long-term outcome of these people. However, the problem is they were comparing 2 different types of minimal invasive surgery versus conventional surgery. So what about the comparison of minimal invasive surgery versus best medical treatment? And the first trial assessing that was the MISTY trial. They used a minimally invasive catheter-based thrombolytic assisted drainage approach. So the MISTY trial has been published in The Lancet in 2019. And here you see how this procedure was done. So here you see a patient with an intracerebral hemorrhage. They were performing imaging pre-surgery, and then they induced a microcatheter into the blood. And then they started to aspirate the blood, but they also infused thrombolytic agents. They used a TPA. And now here you see the result at 7 days. So it is possible to remove the clot. However, do we improve the outcome? And here you see the results of the MISTY trial. Overall, in adjusted and unadjusted analysis, there was no difference in outcome between the 2 groups. There was a tendency that in standard medical care, the mortality was a little bit higher. However, overall, this was a neutral result. So were they using the right technique? We know from the animal experiment that if you induce thrombolytics in the brain of rodents, that this induces a cytotoxic edema. So eventually they have removed the clot, but they have induced a cytotoxic edema. Therefore, the question is, should we use other devices? And as you can see here, there are new devices on the market. One is this kind of Artemis device, the other is the Apollo device, and this is an axon pen device. So these are different devices which have been used. And it is important to see that these devices are quite different. So for instance, the ENRICH device, that's a trial which we are going to discuss in a minute, is significantly larger than, for instance, the device which was used in the so-called MINT study, which we're also going to discuss, and also the microcatheter, which has been used in the MISTI trial, which I just have presented you. And if you look at the diameter, that really matters which device you're using for these people. So the first trial, which was a pilot trial, which I'm going to present you now on minimal invasive surgery, is the Dutch ICH trial. This is a trial which has been presented at the European Stroke Organization conference in 2021. And in the meantime, the results have been published. And what they did a pilot study with 40 people where they performed ultra early removal of the clot. Ultra early means, and that is important for you to say, time from symptom onset to surgery was 6 hours and 42 minutes. It was really ultra early. And then they did two groups. First, an analysis of the first 19 people, and then an analysis of the 21st people in the second group. And they were looking at feasibility and safety. And what you can see here, that the percentage of volume reduction was significantly higher in the later phase. And they also were quicker, and they also were more effective. However, we do not know whether this improves the outcome, and the Dutch ICH trial is currently ongoing, and Karin Klein from the Netherlands is the PI of this trial. The most important trial currently is the ENRICH trial, which has been published in the New England Journal of Medicine. So the colleagues, they performed a trial of early minimal invasive removal of intracerebral hemorrhage, and they randomized 150 people in the early surgery group versus 150 in medical management alone group. It is important to see how that works. So they use this kind of brain path devices which were induced in the brain, and then they induced this tube here, and afterwards they were removing the clot with this minimal invasive transsulcal paravascular surgery approach. And overall, here you see the results. Overall, surgery in these people improved significantly outcome compared to best medical treatment alone at 180 days, shown as the shift analysis of the modified ranking scale. However, it is important to understand the design of the trial. The ENRICH trial used a so-called adaptive design. So they have designed two groups, one group with lobar hemorrhages and one with anterior basal ganglia ICH. And they realized during the trial that people in this group, they were not having any benefit of the surgical approach. So they closed this arm, and then they only proceeded with people in the lobar arm. So overall, the benefit is mainly or is purely driven by people with lobar hemorrhages and not in people with anterior basal ganglia infarction, ICH. And that's very important that you notice that. And here you see the treatment effect, which is shown here in this analysis. So overall, pooled, you see a benefit. However, if you look precisely at the two groups, you see that the lobar people, they have a benefit, and people with anterior basal ganglia ICH might even have a harm. There is another trial which has not yet been published, but has been presented at the neurosurgical conference in the United States, the so-called MINT trial. So MINT was a prospective randomized multi-center study of 236 ICH patients, and they were treated with minimal invasive hematoma evacuation using the Artemis device, which I have shown you before. And they combined the Artemis device with best medical treatment, and they compared it with medical management alone. So overall, they had inclusion criteria of volume of 20 to 80 millimeters, Glasgow Coma scale of 5 to 15. The NIH needed to be more than 5, and they needed to present within 24 hours after symptom onset, and surgery had to be done in less than 72 hours. And then they had these two groups. And here, unfortunately, I don't have very nice slides, but these are pictures which have been taken by the presentation in Houston in September this year. Overall, there was no benefit from the people who were treated with minimally invasive surgery, especially not in people with deep intracerebral hemorrhage. However, there seems to be a tendency of less mortality in people with lower ICH, so which also corresponds and is in line with the ENRICH ICH trial. So there are other ongoing trials, as you can see here. So there are several ongoing trials, and I'm also involved in one of these trials, the EMINENT ICH trial, which is currently running in Switzerland. So for future trials, what is important? Obviously, the surgical technique is important. The timing, should we do it ultra early or should we do it late? The patient selection is key. Age, Glasgow Coma Scale, comorbidity, and NIH. The size, what is the reasonable size in which we should include these people? The location matters, deep, lobar, thalamus, capsule, ventricles. The etiology, we haven't spoken about underlying etiology. And last but not least, end of treatment, do not resuscitate orders. So there are many questions which remains. However, what we can say now is that for people with intracerebral hemorrhage, especially if they do have a lobar intracerebral hemorrhage, the ENRICH trial has shown a benefit. For people with deep, severe intracerebral hemorrhage, the Swiss trial has shown that decompressive surgery might be superior to best medical treatment in these people. So these are my conclusions. Patients with lobar ICH may have a benefit from surgery. However, it would be nice to have more evidence. Decompressive surgery is an option for people with severe deep supratentorial ICH. Patient selection is key. However, further trials are urgently needed. I would like to thank the Bernese ICH study group. These are the senior members, and also most importantly, Professor Jürgen Beck. He's a neurosurgeon in Germany, a good friend, and he is also the co-PI of the SWITCH trial, which I haven't discussed today. If you want to learn more, we have European Stroke Winter Schools, a master, and I would like to thank you for your attention.
Thank you. Thanks for this really excellent presentation. A lot of new and useful information. And I think we can now open the discussion, and I can see many questions coming in the chat. And the first question is for you, Luciano. It's about your study, and there was a person in the chat asking if it's difficult to interpret these extended images, and if there's the need of a specific training, or if a general radiologist working in the emergency room can see those abnormalities without any problem.
Thank you, Simona. That's a great question. And I'll speak based on my experience. When I started this trial, I have zero experience in cardiac imaging, and just by looking at the CTs, after you look at 10, 15, 20 CTs, it's so easy to see the poor opacification of the left atrium or the left atrial appendage. It's very easy to identify the anatomy of the valves, or whether there is anything abnormal, grossly abnormal, of course. So while we are looking at the phase 1 images on the screen, and the other images are being acquired, we can already see if there is a thrombus or not in the left atrial appendage. It's as straightforward as that. Very easy, very simple. Of course, there are other findings such as pulmonary nodules or pulmonary embolism that are more subtle, and those need to be reported by a cardiothoracic radiologist.
Thank you.
I think I'll just add to this, but this is something like how we read CT scans. We don't depend on radiologists, or we use AI, or we interpret ourselves. So probably this is a great opportunity to learn, I think, this new technique and the interpretation that will quickly take decision. We'll be able to take decisions for prevention of stroke. Yeah.
Thank you, Gerard. And if I can make just a short comment,
Yeah.
the importance of acquiring these images before we start thrombolysis is that cardiac thrombi can disappear in minutes after we use TNK or TPA,
Yeah.
and they can disappear as early as 5 to 7 days after we start the DOAC. So if we don't get imaged before TNK or TPA, then the chances of finding a clot are very difficult, are much lower.
Yeah. I think there are a lot of questions for, I think, Dr. Asberg. So there is a hemorrhagic transformation.
I could
Yeah,
pick up on that, on hemorrhagic
Yeah.
transformation, also
Yeah.
on imaging,
Yeah.
because in Catalyst we did not use imaging for this first publication. Some other trials do have imaging, but it was not considered in this presentation or in these results. Hemorrhagic transformation was not considered a contraindication to be part of timing. You could enter, Catalyst, you could enter each of the trials with also with hemorrhagic transformation on the first imaging. So that was not an exclusion criteria. So they are in Catalyst. We did not have this as a subgroup analysis for now, but eventually we will do this. And also the trials that do have imaging can bring further evidence or answers to that question. And I can see it from the chat. There are also some questions about large strokes. And once again, we did not have imaging in this publication or this manuscript, but we do have stroke severity measured by NIHS scale, and there we do not see a difference between the result doesn't alter even considering stroke severity. So
well, if I may, I think we also performed a subgroup analysis on the infarct size of the ELAN trial, and we have published that. And there was no treatment effect heterogeneity, whether it was a minor, moderate, or major stroke. So combining the finding of Catalyst and also the subgroup analysis of ELAN, there doesn't seem to be any major harm to do that also in people with major strokes. We also were looking at people, whether they had hemorrhagic transformation on imaging, and we couldn't find any major differences. I think the only thing where we have to perform further sub-analysis are people with parenchymal hemorrhage type 1 and eventually also 2. So I think there is still some uncertainty, but Catalyst will also look at these sub-analyses.
Thank you, Urs. So if I understood it correctly, in your clinical practice, you start anticoagulation early in the absence of the sign of parenchymal hemorrhage, irrespective of stroke severity.
Yes, that's true.
Very good. And the one question also for you regarding your presentation on minimal invasive surgery. Which do you think it's the optimal time window to perform this intervention?
That's an excellent question. So I think, first of all, I think there is now quite good evidence that people with lower ICA should be treated with minimally invasive surgery. Nevertheless, I think, or from my perspective, I'm rather cautious in people with a severe cerebral amyloid angiopathy, because we know that the bleeding complication in these people are quite high, and I would be rather cautious, if I do have a patient with a superficial cirrhosis and stuff like that. So that's something which you have to keep in mind, and we do not have enough information of the trials on this particular subgroup. So, but overall, I think blood does not belong into the brain, and I would do rather early in people with lower hemorrhages. Regarding the deep ones, we do not have any evidence so far that this is a beneficial approach. And I strongly think that we need further trials, we need more evidence. So people with deep ICH, they should be, whenever possible, be randomized in trials.
Yeah, I think I'll add further to that Chinese trial, which was presented in Abu Dhabi. They compared that craniotomy and endoscopic aspiration and minimally invasive surgery. Now, if I'm correct, I think they also found benefit in basal ganglia deep hemorrhages. I think it needs to be further explored, as you mentioned. My question is, there are several equipments available, instruments available to aspirate the clot, and it is something like similar story of thrombectomy, how the device is refined with ongoing trials, and then I just wanted to know what would be the cost of this particular equipment, and in certain parts of India and Asia, we have more than 30% hemorrhage. There is eastern part of India, it is 65% hemorrhagic strokes. So it will be very good for us from the Indian Stroke Clinical Trial Network to explore this opportunity. And yeah.
Yeah, first of all, I think that's a very, very, very important point. So coming back to your first comment, yes, that's true that the Chinese trial, which has been presented at the World Stroke Congress, showed the benefit, especially for the deep ones. Nevertheless, they did not compare to best medical treatment. So they just compared to conventional craniotomy. And overall, we do not know whether it is better than, just best medical treatment alone. And I think, therefore, we need the proof for the deep ones that it is really better than best medical care. Coming to the second comment or question, what is the price of the device? To be honest, I do not know the price of the Enrich device, which was this kind of brain path device. I only know that the other device, the Penumbra device from the Artemis device, which has been used in the MINT trial, that's quite expensive. It is really, and you also need a suction pump, which is connected then to that device. So even for Swiss standards, which are quite high, this is considered as a expensive device. And therefore, if we make therapies available, they need to be feasible and affordable around this world. And I therefore think we need also independent academic research, which is focusing on simple methods, just to take that bloody clot out of the brain. I think the size of the device matters. If you look at this brain path device, it looks huge, and therefore I'm not surprised that such a big tube in the basal ganglia of my patient does not improve the outcome. Whereas if you can suck the blood through a very thin catheter, then eventually this might improve the outcome. But I don't think we are yet there. But also the comparison with endovascular trials is very good, because at the beginning, we had the Mercy devices, and they were not linked to good outcomes. So the devices need to become better. We need engineers and entrepreneurs which help us to tackle this question.
Yeah, thank you. Yeah. I think there are a few questions about ICH only. Some US neurosurgeons are evacuating deep hemorrhages with minimal techniques. So is this a mistake or?
Well, I know now. We can't say that's a mistake. We do not have the evidence. That the point is, I know that in the United States, the group which has done the Enrich trial, they're now currently running another trial focusing on the deep ICH people. So I think that is what needs to be done. And whenever possible, I would really encourage people to participate in trials, because we don't know whether such an intervention is beneficial for our patient. And we need the answer. That's our global challenge to answer these questions.
Yeah, thank you. There's one other question for you, Signil. When should I start DOACs in AF patients with the petechial hemorrhagic transformation of acute ischemic stroke?
I'm sorry. In patients with parenchymal pH 1 or 2, I think
pH 1 and 2.
Yeah, I think maybe that's one already answered by Urs. In none of these trials.
They are asking if you wait that CT is completely negative for the blood, or if you start anticoagulation even in the presence of small signs of pH1.
I will not answer this based on Catalyst because it's not part of Catalyst, but I could answer it anyway. And I do think that sometimes we get very scared when we see blood. Blood is quite visible on imaging, so even small spots make us scared. And the larger the spots are, the more terrified we get. But we do not have to wait for all the blood to disappear. We should aim for a stable patient, and then we can start. But I will not give you particular days on this, because this was not all of them were not. pH2, for example, was not included in this setting, and nor was primary. I think there was a question about primary ICH, and that's not part of this topic. I do have opinions, but not evidence to bring forward now. Urs, would you like to comment on something on which you have looked in the ELAN subset? ELAN is one of the trials in Catalyst, but ELAN has more imaging and also already looked at imaging.
Yes, I think we had an imaging-based approach because me as a physician, I always look at the images before I start anticoagulation, and I think a lot of people do that as well. So we have information on both CT and MRIs. And the first thing you have already answered, infarct size apparently does not matter. So whether an infarct is small or large, the risk of producing an intracranial hemorrhage is not increased when you start early. And I think, therefore, all the trials, especially Catalyst, is reassuring us as physicians that we do not have to be anxious. All trials, or most trials, have shown if you wait, the risk of having ischemic recurrent events is increasing. And therefore, there are so many arguments to start early. Looking at hemorrhagic transformation, as already mentioned before, if you have some small petechia or even a small blood in the brain, it doesn't appear to increase the risk of intracerebral hemorrhage. The only uncertainty is about pH1 and pH2 from my perspective. And we need to further explore the images of Catalyst in order to find whether there is a safety signal or not.
I think there is one question to Luciano. Probably must have been answered. I think it's a repetition. What is the scientific rationale of adding non-gated extended CTA, and what extra diagnostic value it adds to the context of ischemic stroke?
Yeah, thanks for the question. It's pretty straightforward. There's a large proportion of patients who have cardioembolic sources that remain undiagnosed after basic stroke workup, and because of that, is that at least in part, ESOS patients have such high recurrence rates. So there is a need to improve the way in which we detect cardiac thrombi, and by doing a CTA going down to the heart, it's pretty easy. And we can, as I said before, we can do it before the thrombus disappears, which is the main problem with when patients get IV thrombolysis or anticoagulants.
Yeah, thank you. I think there's a question to Dr. Fisher. Is there an inclusion and exclusion criteria for lobar ICH? Is there a protocol or algorithm so that we can get these patient faster evaluation for eligibility?
Yes, I think if you want to translate the evidence from randomized clinical trials into your clinical practice, you just have to go to the study protocol of the ENRICH trial. And to be honest, I don't have all the inclusion-exclusion criteria now here in mind, but this person who has the question can send me an email and I will send them the ENRICH trial immediately. So, but I think it needs to be, obviously it needs to be lower, it needs to be a certain neurological deficit, as shown in the enriched protocol.
Okay, thank you, everyone. I think it's a time to close. Yeah, it was really an excellent webinar. I wish to thank all the speakers for their excellent and very important presentation. And I wish to thank my co-chair, Professor Pandian, for organizing this important webinar. I want to remind everyone that next year that we will have the European Stroke Organization conference. It will be in May in Helsinki, Finland, and I hope I will see many of you there. So thanks, everyone.
Yeah, thank you. Yeah.
Thank you so much. Bye-bye.
Yeah, thank you. Bye-bye.